You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for January 19th, 2024. This week, some listener feedback, Bempedoic Acid, off-label PFO Closure, and Palliative Care. Let's do a little listener feedback. Last week, I reported on 5-year results of the STOP-DAP trial, which was basically clopidogrel versus aspirin, and clopidogrel looked better in terms of both reducing CV events and bleeding, and this was in post-PCI patients. Well, Dr. Andre Aman, writing on the heart.org website, pointed me to another study of clopidogrel versus aspirin over the long term, and this was a report from the South Korean JAMA extended study, and that was published in Circulation in 2022, and I'll link to it. This was a similar clinical situation post-drug-eluting stent. At 1 year, patients were randomized to clopidogrel versus aspirin. After nearly 6 years, the primary endpoint of a composite of death, MI, stroke, ACS, and bleeding was reduced by 28% in relative terms and in 4% in absolute terms in the clopidogrel group. Bleeding, too, was reduced by 28%, 4.5 versus 6.1% in the clopidogrel arm. Now, look, I'm an outside observer here looking at the post-PCI space, but I do see a lot of patients with AFib who are on different antiplatelet drugs, so I'm interested. To me, clopidogrel surely looks better than aspirin for long-term single antiplatelet therapy. Now, the emphasis here is that I'm an outside observer. I thank Dr. Aman for citing an important study in this space, and I really appreciate this sort of feedback, so please keep it up. I read those comments and I learn from them, so thank you. Next topic, and we'll spend a fair amount of time talking about bempedoic acid because JAMA Cardiology's published another analysis from the CLEAR Outcomes trial. CLEAR Outcomes was originally published in the spring of 2023, and it was presented at ACC. This was bempedoic acid versus placebo. The trial enrolled 14,000 statin-intolerant patients with heart disease or high risk for heart disease and statin intolerance and high LDL. The mean LDL cholesterol level was 139 milligrams per deciliter. In CLEAR Outcomes, bempedoic acid reduced LDL by a modest 20%. In the main trial, the MACE composite outcome of CV death, MI, stroke, coronary revascularization was reduced by 13%, hazard ratio 0.87, with pretty tight confidence intervals of 0.79 to 0.96. The p-value was highly significant, and this was definitely signal, not noise. But, the absolute risk reduction was only 1.6% over 4 years, and there were no differences in CV death or all-cause death. The drug reduced only non-fatal outcomes, and the main drivers of this positive trial was non-fatal MI and coronary revascularization. Now recall that bempedoic acid is a once-daily oral prodrug that is activated in the liver, and it inhibits the ATP citrate lyase ACL, which acts upstream from the HMG-CoA reductase, which is blocked by statins. As with statin treatment, bempedoic acid reduces hepatic cholesterol synthesis, and it results in upregulation of LDL receptors on the hepatocyte surface, which then enhances clearance of LDL cholesterol from the systemic circulation. Now, this summer, there was a strange publication which I covered on the July 7th episode, and I'll have a link to that. This was where the authors of CLEAR Outcomes split the main group of 14,000 patients into subgroups. Those with established vascular disease, otherwise known as secondary prevention, and those with primary prevention, those with high risk of disease but haven't had disease. The primary prevention cohort, or those at high risk for cardiac events but without established disease, represented about 30% of the main trial, or about 4,200 of the 14,000. In this subgroup, the hazard ratio for the primary outcome was highly positive for bempedoic acid. It was 0.70, or a 30% reduction, and it was statistically significant. But even that amount of slicing of the data, right, primary care versus secondary care, that wasn't enough. The authors this summer broke out CV death and all-cause death, and they found that bempedoic acid reduced these outcomes by 39% and 27% respectively in the primary prevention cohort. Now, this selective publication of only one subgroup got under my skin because, number one, they didn't publish the secondary prevention cohort. So it's a subgroup analysis where they only presented one subgroup. The problem is, if you believe that these huge reductions of death and cardiovascular death are signal, not noise, and you also believe that the main trial found no decrease in death and only a 13% reduction in non-fatal CV outcomes, then it must be that the secondary prevention cohort must have done worse with bempedoic acid. And of course, that belies much of what we believe in cardiology, namely that LDL cholesterol reductions are going to lead to greater absolute reductions in patients with established disease and higher baseline risk. Now, I will link to this, and I mentioned this flawed paper in the summer because I have to say that the CLEAR Outcomes authors have affected my Bayesian priors about any new sub-analysis in a very skeptical way. Now to the new analysis, published on January 17th in JAMA Cardiology. This was a post-hoc analysis that presents the results of CLEAR Outcomes with the primary outcome of total cardiovascular events. Remember that the main trial chose time to first event. Now, the thinking behind using total events is that some patients, especially those at higher risk, may experience multiple clinical events over time, and, quote, the totality of cardiovascular events presents considerable health, social, and economic challenges for these patients. Of course, choosing total events allows for more events, and more events means greater ability to sort signal from noise, although Professor Bill McIntyre told me that, yes, you get more events, but also the confidence intervals are wider. I'm not sure exactly why that is. But the idea of measuring total events is not unprecedented. The Paragon HF trial of sacubitril valsartan measured total heart failure hospitalizations, whereas some previous HFpEF trials had measured time to first heart failure event. So anyways, for this trial, for this report, 14,000 patients, mean age 65 years, about half male and female. Median follow-up was 3.4 years. And in this analysis, they had 1,746 total primary outcome events. They called this MACE-4, right? CV death, MI stroke, and coronary vascularization. So 4 parts of the composite. Then they also had 915 events in the MACE-3 events, which was cardiovascular death, MI, stroke. So the results in time to first versus total, and I'll present these in absolute events per patient year and hazard ratio. The hazard ratio for the 4-point MACE, the first events, remember it was 13%, hazard ratio 0.87. And in that main trial, the rate difference was 0.47 per 100 patient years. That because it's only 3.93 versus 3.46. So just pause there for a second. We're talking about a less than 1% per 100 patient years risk reduction in the main trial. The hazard ratio for the 4-point MACE, when you're looking at total events, was lower at 0.80, or a 20% reduction here. The rate difference was 1.2 per 100 patient years, and that corresponded to 6.2 placebo versus 5.0 100 patient years. So just to review, for the 4-point MACE, it was 13% reduction in when you're looking at the main trial, which was time to first event, but a 20% reduction when you're looking at total events. Now, the hazard ratio for the 3-point MACE, which is arguably a little bit better or harder endpoint because you're getting coronary vascularization out of there, in the main trial, the first event analysis, the hazard ratio was 0.85, so a 15% reduction. But again, the rate difference between the two arms is only 0.4 per 100 patient years. So a tiny absolute risk reduction. The hazard ratio for the 3-point MACE when we look at total events was about 0.83, so 17% reduction, but again, the same rate difference, 0.5 per 100 patient years, so a very small absolute difference in events. So the impact of counting total events was greater on the 4-point MACE, and it was driven mostly by coronary revascularization. There was not much of an impact on the 3-point MACE. This total event analysis still had no effect on CV death or all-cause death. The authors make note of the greater effect of bempedoic acid with increasing numbers of events. For instance, the hazard ratio for the treatment comparison for the first event, I've already said, is 0.87. For the second event, 0.74. For the third event, 0.69. And for the fourth event, 0.51. So, my comments. First is a technical issue. In some ways, I kind of like the total events analysis, and I wonder why more trials don't use it. It would seem to increase the power, but I do get that patients who have recurrent events may be different in baseline characteristics than the main trial group. In fact, the authors write, quote, "In this analysis, those individuals experiencing multiple clinical events differed in terms of demographics, use of other lipid-lowering therapies, and baseline levels of lipid and inflammatory biomarkers." Now, I wondered about the two types of analysis, and so I put a question up on Twitter, and Dr. Biondi Zokai from Italy posted me the ChatGPT response, which is pretty darn good. So this was asking the question, what's the difference between the two time to first or total events? And there were like 5 points. First, time to first event is simpler and more easy to interpret. Okay, that's good. Second, time to first event analysis avoids the bias of dependent events. Right? This is like recurrent events that may not be independent of the first event. You could think that an MI may then predispose to a stroke or a coronary vascularization event. Time to first event minimizes the effect of post-baseline interventions, so this is also important. Patients may receive additional therapies after a first event. Here I'm thinking extra antiplatelet therapy, for instance, after PCI, for instance. Time to first events require less complex statistical tests. That's always good. But total events may have their place, especially when the frequency of recurrent events is clinically important, and I can think of heart failure hospitalizations as one of those cases. My overall take of the total events analysis was similar to the main analysis. Bempedoic acid works, but its effects are modest. The absolute risk reductions are 1.2 per 100 patient years for the 4-point MACE and only 0.5 per 100 patient years in the harder endpoint of 3-point MACE, which is MI, stroke, and CV death. Okay, Professor Derek Connolly from the UK wrote to me on Twitter that bempedoic acid fills an important unmet need, at least in the NHS system, because statin-intolerant patients often go with no LDL cholesterol reduction. And I also understand that if you combine bempedoic acid and ezetimibe, you're going to get more LDL cholesterol reduction and perhaps greater reduction in events. I think the question, of course, comes down to cost, and that can be both a society issue and also a personal issue. This also came up in a little Twitter thread conversation. An anonymous person named Nick says that I purport to be the arbiter of value. Nick's contention was that medical science has to show that a drug is safe and that it's effective, then a patient can decide about cost, and which that comment makes me smile, right? Because I'm pretty sure that most of my patients who are shown this data, they might pay a statin-type price, a generic price, but I think many of them are very unlikely to pay hundreds of dollars for a drug that has a very modest reduction in future non-fatal events. I mean, I'm just thinking about how much difficult it is to get patients to pay for oral anticoagulation, which have very strong data as far as a benefit. Oh, here's another question I have for the proponents of bempedoic acid. I see a potential contradiction in their reasoning between their primary prevention paper in the summer and this total event paper now. This summer, they're trying to convince everybody that bempedoic acid was best for the lower risk primary prevention patients. I mean, it's reducing death and CV death. But now they tell us that the hazard ratio is better when you use total events because these incorporate those high-risk patients who have multiple events. In fact, they write it specifically in the abstract. They say, quote, a lower hazard ratio for protection with bempedoic acid was observed with increasing number of MACE events experienced by patients. So I ask, which is it? And when you persuade me this way, I'm tempted to think that I'm hearing a lot of spin. Finally, I reiterate the most important message with bempedoic acid. This is the take-home. Statin drugs are far more studied and proven effective. They even reduce mortality in secondary prevention cohorts. We should always prefer statin therapy. We should also remember the very elegant Samson trial, which showed that statin adverse effects are mostly due to nocebo effects, and we can mitigate these by being skilled and empathic clinicians. All right, next topic is off-label PFO closure. Andrew Goldsweek from Bay State Medical Center in Springfield, Massachusetts, along with a number of other co-authors, have published a provocative paper in Circ Outcomes regarding use of PFO closure devices over a 13-year period. Now, I've never met Dr. G, but I am very partial to this study because I grew up near Springfield, Mass., just over the border in Windsor Locks, Connecticut. I am also partial to this paper because it represents a very good use of real-world observational data. They didn't do any non-random comparisons and statistical adjustments. They used real-world data to describe what's happening out in the real world. They took an Optum Labs database, which is a commercial insurance database, to look at PFO closure indications. Now, recall that PFO closure is indicated very narrowly for the treatment of patients who have a PFO-related embolic stroke, and this is in adults less than age 60. I have long opined on PFO trials. I have a PowerPoint lecture wherein I critically appraised the regulatory trials. I once gave this lecture at ESC, but sadly, I was the last lecturer in a session, and the previous speakers had used up half my time, and the session chair cut me off, and I did not get to present the most important slides. I'll sum up the issue briefly. The early PFO closures were mostly negative for PFO closure. The later trials showed benefit for PFO closure in patients in prevention of recurrent stroke, and the reasons relate to multiple factors. One is probably better patient selection. The later trials chose patients with PFOs that were more likely to cause stroke, and they were also less likely to include oral anticoagulation. The earlier trials had studies that also had oral anticoagulation, which of course mitigates the benefit of PFO closure. The anticoagulation issue here really begs the entire question, that is, when you compare PFO closure to aspirin, which is the regulatory trials, you may be comparing a device to the wrong treatment. That is, if your thesis is that PFO causes stroke because of venous clot, paradoxical embolism, we have oodles of studies that show that oral anticoagulation is better than aspirin for venous thromboembolism. So a PFO closure trial versus oral anticoagulation would be very likely to be negative, or possibly even better with oral anticoagulation. But of course, the other side of the coin here is that a 40 or 50-year-old cyclist or runner is not going to want to be on lifelong anticoagulation. So if a device works to prevent recurrent stroke, great. Anyways, PFO closure has very tight indications in the real world. So what the authors of this paper did is that they showed that once a device is on the market and there are no national coverage decisions like there are for pacers or ICDs, off-label use is very common. First, they found that PFO closure grew. It increased from 4.75 per 100,000 person years in 2006 to 6.6 per 100,000 patient years in 2019. They then found patients aged greater than 60 accounted for nearly 30% of closures. And right there, this is a bad finding because the trial specifically enrolled young people. The CLOSE trial, one of the later trials published in New England, the mean age of patients in the CLOSE trial was 42 years. Now, the reason age matters is that one of the tenets of identifying PFO-related stroke is that you have to exclude other causes of stroke, and older people tend to have other causes. Procedure volumes corresponded weakly with supportive clinical publications and device approval among patients with PFO closure. 58.6 underwent closure for stroke and systemic embolism. 58%. They found that approximately 10% of patients had PFO closure for transient ischemic attack, TIA. This is a weak indication because entry criteria for trials were mostly stroke, not TIA, and everyone knows TIA is a very difficult diagnosis. Approximately 9% of patients had PFO closure for migraines, which is really bad because there's no compelling data. 22% for other indications, so it's hard to know what to make of this. And here's a really bad one. 18%, almost 1 in 5 patients, had atrial fibrillation at baseline. To me, this is the worst because if your patient with stroke has atrial fibrillation, you have a darn good reason for the stroke, and that patient should be on anticoagulation, not having a device closure. And then 12% of patients developed AF post-procedure. And of course, this is a commonly ignored complication of PFO closure. Proponents say, don't worry, John, don't worry. Mostly it's just in the short run. But I'll tell you, the problem with AFib in the short run is that sometimes it gets established in the long run. So my comments on this paper, I find this paper quite sobering. Now the editorialists, there's an attached editorial, are kind to the PFO closure proponents and point out the weaknesses of insurance claims data, and they have a point. There are nuances of diagnosis that don't often come out in insurance claims. But we as a field should look hard at this data, and then we need to look inward. I am asking, if we are an evidence-based field, why does it require a sledgehammer like a national coverage decision to curb such poor choices in using these devices? I mean, even the regulatory trials for PFO closure were not that robust. I mean, in addition to the use of aspirin as a control, which is questionable, and selection of the proper PFOs to close, the trials were statistically fragile. Many of these trials had missing data that far exceeded the fragility index. For instance, the RESPECT trial had a fragility index of 1. If one patient, one outcome was in the other column, the p-value would no longer have been significant. But it had more than 10% missing data in both arms. When your missing data is 10 times the fragility index, the trial's fragile. My point here is that even when we are 100% careful in choosing the exact right patient, a big PFO, no other cause, young person, the perfect patient, we're still a little bit uncertain about benefit. But when we choose patients that are off-label or off the reservation, our level of certainty is even worse. So I say good on Dr. Andrew Goldswig and his co-authors and Bay State Medical Center in Springfield, Massachusetts. All right, final topic, a little bit briefer, palliative care. JAMA has published, to its credit, 2 excellent RCTs looking at palliative care. I will focus on one of them because I think this is an important issue for cardiology. This podcast, well, I guess me, has long felt that the biggest problem with heart failure care is that it is too often heartless. I mean, we have great therapies for these ambulatory, robust patients with heart failure. You know, those who have the strength and resources and support to get into heart failure clinics and take medicines and afford medicines. For these patients, our drugs and devices work beautifully. But for the elderly, the frail, the heart failure patient with many comorbid conditions, our robotic, algorithmic care is often heartless. Instead of drilling down on what's really bothering these sicker patients, like their symptoms, we struggle to get them to take pills that A, drop their blood pressure, B, worsen renal function, C, increase the risk of recurrent admissions, say from falls, and D, put them into financial distress. And this is where palliative care could come in and help us. Palliative care are like friends for people with serious illness. They specialize in the relief of symptoms, not titration of medicines. I think we underuse palliative care, and we grossly mistake palliative care for hospice care. It's not the same. Many hospitals boast about having palliative care, but it really isn't true palliative care. It's more like a place to go when patients need help in their actively dying phase. And this is why I love the recent RCT from the UPenn group done in 11 hospitals. This was a pragmatic trial carried out in about 24,000 inpatients, older adults with serious disease. Ordering palliative care consultation by default for eligible patients while allowing clinicians to opt out was compared with usual care in which clinicians could choose to order palliative care. So it's a nudge. Basically, palliative care orders just came up, and if you didn't want them, you had to take them out, but they came up by default. The primary outcome, however, was not a good one, and I'll come back to that issue. The primary outcome was length of stay. Secondary endpoints were palliative care consult rate, discharge to hospice, DNR orders, and inpatient mortality. The results. Now, these were older patients, 78 years, so right off the bat, they're studying patients like I see in the hospital every day. The primary length of stay outcome was not different. Patients in the treatment arm, however, had a 5x higher odds of getting a palliative care consult. Patients in the treatment arm received palliative care faster. Patients in the treatment arm had a 40% higher rate of getting DNR orders at discharge, though the absolute rate of DNR orders was still quite low at 37%. Patients in the treatment arm were 30% more likely to be discharged to hospice. Inpatient mortality rates were similar. So, my comments, let's make some comments. First, in-hospital mortality was unchanged, but it would not matter if it were less or more. Mortality should not be an endpoint for palliative care studies. It's not the point. The choice of endpoint makes this a non-significant trial like in the books, but I think this is a hugely positive trial. Why the authors chose this endpoint of length of stay is hard to know, but I suspect it had to do with negotiations with administration. In the paper, the authors call this the stakeholders. But think about it. The purpose of palliative care is not to reduce length of stay or to reduce cost. It is to relieve symptoms and improve quality of life. I mean, if patients left the hospital one day early, that may or may not relieve symptoms. It could actually worsen quality of life if they're readmitted at a higher rate. And I speak here not as a palliative care or hospice expert, but we fail Medicine 101 when we promote palliative care or hospice care as cost-saving measures. That's a failure. That's not what it's for. So I like the secondary outcomes better. These are the story of this study. More palliative care consults, faster consults, more DNR orders. These are very important measures for these 78-year-old patients with serious disease. One caveat is that although this simple nudge-like intervention, that is just making palliative care orders a default, it worked, it requires having a proper palliative care team, not just a nice unit for patients who are actively dying. The crisis, I think, in low uptake of palliative care, especially in non-cancer settings, is the businessification of medicine. Doctors and hospitals are incentivized to do more to elderly patients with serious disease, right? We're incentivized to do appendage closure and cardiomems and loop recorders. We are sort of disincentivized to provide palliative care. Since the point of palliative care is not to decrease cost, and administrators are also not exactly incentivized to promote palliative care. Therefore, I can only see the increased use of palliative care as an organic grassroots movement. We have to do palliative care not because it makes money, but because it is the right and moral and just thing to do. Okay, so that's it for this week in cardiology. As always, I'm grateful that you listen. We're getting close to 800 ratings on Apple Podcasts, so thank you very much. Please take the time to rate this podcast. Write us a brief review. If you disagree with something, teach me something in the comments, please. I learn a lot from these. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.